I know I'm a minute early today, but there's error messages going on, so I'm not sure. I can't see any chat. Hello, I'm Dr. John Kruse, and today's question and answer hour is open for questions about the videos I released this past week about ADHD in general and more broadly about mental health. And I am getting some error message. There's no chat place to type. So I don't know if you can. I'm not sure what's going on. It says youtube.com has refused to connect, but it also says I'm live. Um, and I tried rebooting just before I started. Hello? I'm going to just try rebooting and starting over. Hello? Hello, I'm not sure what's going on today. This is Dr. John Kruse, and hopefully I am live now. I'm on my laptop, which I am not usually on, instead of the desktop, and I'm getting weird error messages on the other. Anyway, here I am, open for an hour. Questions I can answer on the video released on ADHD in general and on mental health. It actually would be helpful if Max or someone else lets me know whether I'm really live now or not. So the comments I make are not intended for specific medication recommendations. They're for informational purposes only. And I do have a few questions left over from last week. I'll summarize the video that came out this week. It was on folate, vitamin B9, and ADHD. And although there are a flurry or a number of comments on Reddit and other online places where people swear that folate helped with their ADHD, and it may well, folate is essential for making DNA, mRNA, manufacturing certain neurotransmitters. So if you have a shortage, you will probably eventually, sooner or later, have neurologic and brain issues. But there are no formal studies so far clearly demonstrating benefits for folate for ADHD. That doesn't mean it doesn't help. It just means a lack of evidence. And the form of folate you take may matter. There are a substantial number of the population who have deficits in a certain gene, MTHFR gene. I'm live, but you can't hear me. Can you hear me? Okay, so it is working. So the three questions left over from last week, and I'm not sure who asked the questions. One was asking about my most surprising off-label medication response. And The more I've thought about it, I don't have too many surprising off-label responses. I guess particularly because if I tried something off-label, I thought it was at least had a likelihood of working well. So my most surprising patient responses to medications have been more things that I didn't think fit with what physiologically could be going on. For example, people having side effects that they attributed to fluoxetine or Trintellix or some other medication that has a fairly long half-life of several days, and then claiming the very first day they went without it, their side effects miraculously all went away, which to me suggests highly that the side effect was a psychosomatic effect rather than a direct physiologic effect. Um, so James Alexander had a question about p-values and p-hacking and sort of how prevalently do I see problems with this in psychiatry, mental health research. So p-values are just the probability values across biological sciences anyway, a probability of 0.05. So that means 5 times out of 100, you might get that result finding, and probability of lower than that is considered, again, even better or stronger, that it's less likely that it could have arisen just by chance. P is the practice of doing so many more. If you do enough tests by statistics, some of those will turn out to be positive, even though they're truly not. And I'm not saying that doesn't go on in research, and I'd say particularly in my talk on creatine and when I wrote about it, there's a Brazilian statistician and researcher, Ivor Egert, I think is his name, who has an in-depth knowledge of statistics and has criticized much of the research based on too many testing and sophisticated issues with statistics. My issue more often when I'm looking at studies is just looking at whether the study itself is well designed and I found this recently with the meta-analyses when I actually researching folate. There were at least 2 different meta-analyses on folate and mental health claiming that there were studies showing ADHD responded to folate. And the studies, about the only one that's been done in a random control style, was adding folate or adding placebo onto kids who are already taking methylphenidate, and the study found no improved benefit for ADHD symptoms. It did find a decreased problem with appetite loss in the folate group, so there was help that way. But several of or 2 meta-analyses both included that as evidence that folate was effective for ADHD, and another one of those meta-analyses included studies which looked at a multivitamin supplement where there were at least 20 different minerals, vitamins, and other substances, and claimed that showed evidence that folate helped with ADHD. So I think, again, my forte is not in statistics. It may be more in sort of looking at the design and sorting out what's actually been studied. And then, and again, I'm not remembering who sent it, they were asking what was the research on the genetics between the broader autism spectrum and Asperger's in general. So there have been criticisms and critique that Asperger's, which was formerly in the DSM, is now just considered one end of the autism spectrum, presumably the higher functioning, better performing end. And I did find a very interesting, it looked like it was well done genetic analysis. And one thing that they looked at 30 different domains on the genome where genes for autism were associated with autism. And in all 30 out of those 30 domains, people with Asperger's were registering gene variants in those genomic regions. However, there were 3 genomic regions that were specific to the Asperger's population that weren't represented in the general autism spectrum groups of individuals. So that's strongly suggested that, yes, Asperger's is on the spectrum or in the family of autism-like conditions, but there are unique aspects to it that do make it, at least in some genetic realm, somewhat different. So that's what I learned there. And I see there are lots of questions. I will have to put my glasses on because my screen is smaller today. So Jack asks, do I have any Medium article about ADHD in children? No, I mean, I've never specialized or worked directly with children, so most of my focus has been on ADHD in adults. I mean, certainly many of my adult patients with ADHD have children with ADHD, but no current writing on it. So Dennis asks, euphoria is sometimes described as a side effect of stimulants. Is it really an adverse experience or an improvement in life? Yeah, so I mean, euphoria's definition, I think, is something like true feeling or anyway. Usually when it's used, it implies that someone is overly optimistic, overly positive relative to the situation or what's going on. So whether that's actually an adverse effect or a side effect, I think winds up being a semantic issue. I mean, can it be problematic if someone is out of sync with their society or environment in terms of evaluating something as highly positive and others aren't? That could be problematic. This is, I'm not sure what's going there. Okay. So James Alexander asks, do Strattera, Cymbalta, Qelbree actually have any advantages over extended release stimulant plus immediate release booster combos, like taking Vyvanse in the morning and Adderall in the evening, specifically in terms of providing around-the-clock coverage for ADHD patients? Atomoxetine, duloxetine, and viloxazine are promoted as working 24/7 for ADHD, but are there any real benefits for this coverage-wise if the extended release stimulant plus higher booster combos provide symptom relief during the patient's waking hours anyway? So there may be studies looking at this, but one is, I mean, one angle of what James Alexander is pointing out is some of these claim that these, and I would say the evidence is actually best for quanfacine, which is working slowly and indirectly, that there is round-the-clock coverage there. I don't know that anyone has woken up patients during the night or studied actually people during 24/7 to see whether coverage is really that thorough. Again, I think a lot of this for these antidepressant-like ADHD medications is making assumptions that they work slowly, gradually for depression, and therefore they must be working the same way for ADHD. Whereas with bupropion, duloxetine, atomoxetine, I have patients who say they work immediately if you are at a therapeutic dose, and that most of their benefit does seem to be their immediate effects, and that they are probably not particularly giving round-the-clock coverage. But I don't know of actually rigorous, and I mean, part of it that's complicated is you are going to have circadian rhythms in your executive functions. So, you know, how good your what you expect of your performance when you wake someone up in the middle of the night or you keep them up late to study them is going to be fluctuating on a circadian rhythm anyway. Yeah, so I don't know that that claim's been rigorously tested. And again, most of what I see with norepinephrine reuptake inhibitors or dopamine and norepinephrine reuptake inhibitors is that most of their benefit is direct and immediate and should be, I mean, is there some still going to be present overnight? Yes, but that would be true with stimulants as well. So JK Skatehills asks, any tips on keto? So I do have a video on keto. I do have a Medium article as well. At least when I wrote that and recorded that, which I think was at least a year ago now, there were not any formal studies on keto for ADHD. I've seen just in the last month some studies on keto and depression, which there were very few of before, or mostly along the lines of case reports. So one is that there can be, some people do have adverse effects to keto diets, so it's not something to be jumped into lightly. I think particularly with someone with ADHD is having a schedule of when you're eating as well as what you are eating is important. And in terms of what's going to help you adhere or stick to that schedule, I think visual reminders are helpful. I don't know what else to say. And the other thing to emphasize is that if you think you're on a keto diet, you probably should be doing blood testing to make sure, because people vary in how readily they can switch into a keto state. And some people doing the same dietary regimens or manipulations are in a keto state and some aren't. So individual bodies vary. That's what I'd say there. So James Alexander asks, why do selective norepinephrine reuptake inhibitors like atomoxetine cause sexual side effects with a similar frequency and degree of severity that of SSRIs, despite serotonin receptor activity being the primary mechanism through which SSRI sexual side effects are thought to occur? So one is, it depends a lot. I haven't actually seen any studies that use the exact same methodology to compare SSRI versus NRI sexual side effects. So I would be personally surprised if using the same measurements, you got the same rates of problems, because my clinical experience and my brain research experience does implicate that the SSRI and serotonin reuptake can be problematic. So jumping backwards in time, when Prozac, the first SSRI in the United States, came out in the 90s, the claim was only about 2% of people had sexual side effects. So one is, compared to the old tricyclics, which moderately often caused in males erectile issues, that's fairly uncommon in SSRIs. Not that it can't happen. So most of the common SSRI side effects are decreased libido and requiring more physical stimulation to get to the point of orgasm. So when researchers and individuals didn't know it could be a side effect, people didn't voluntarily provide that information. So some of the early studies claimed only 2% sexual side effect rates. As people became more aware this was possible, more people endorsed it or were willing to discuss it, or doctors and studies more actively searched for that. And most studies indicate about a third of people, and it's clearly higher dose, more likely. Paxil may be a little worse than the other SSRIs, but they're all pretty close. So 30% rate. The other interesting thing, and I haven't looked recently, but back in the 90s and the aughts, there were actually fairly significant differences in sexual side effect rates and actually overall side effect rates, headache, nausea. In the US studies, much higher rates of side effects than in the European studies, like double or triple rates. So they'd be 25 to 30% in the US studies, and again, 5, 7, 8, 10% in the European studies. Do I think they're really genetically different populations? No, I think people ask questions differently. I think people have different expectations, so there can be nocebo effects. And particularly with sexual side effects, it depends a lot on what you're asking. So and I'm oversimplifying and overgeneralizing, But again, and I haven't seen recent studies to this effect, but if you asked Americans the most broad question about sexual side effects, which is there anything less than perfect about your sexual life? About 2/3 of Americans say yes, and only about 1/3 of Europeans in the studies were saying yes. So there are studies claiming 2/3 of people on SSRIs have sexual side effects, but those are usually, if you go and look at what tools or measurements they're asking pretty much, is there anything less than perfect with your sexual life? So so again, there may be studies finding similar rates of side effects, but I until I see the data myself, I don't believe that norepinephrine reuptake agents are going to have the same rate of sexual side effects. And specifically, I've seen people be rescued from the sexual side effects of SSRIs by stimulants, by switching. And it's also clear that the SNRIs have rates of sexual side effects substantially lower than the SSRIs. And as you move from venlafaxine, which is predominantly serotonergic, to duloxetine, which is evenly balanced, to milnacipran, which is stronger on the norepinephrine end, your rate of sexual side effects decreases, as if norepinephrine is rescuing many people from the serotonin side effects. So there may be outlier studies or studies done differently, but that's the data that I'm aware of and what I see clinically. Flynn asks, what are my thoughts on the state of psychiatry in hospitals, and how different are the approaches and treatments in psychiatric urgent care compared to a classic clinical setting? So one is, I haven't been in a hospital setting since training, so most of what I'm gleaning is from patients who've been hospitalized in the past 30 years. One thing that's shockingly, so one is, and this is not just in psychiatry, it's all across medicine, that particularly in the last 3 decades, there's been the development of this. We have people who are called professionals who are hospitalists. So in the old days, the doctor, your outpatient doctor, tended to follow you, come in and visit on round, when their patient was in the hospital. This is non-psychiatric. And so there is considerable communication and overlap between treatment. And these days, once someone gets into the emergency room and then admitted to the ward in the hospital, the doctors in charge of their care are the hospitalists, and they may discontinue all medications. They may never bother calling or contacting the outpatient doctor in medicine or general psychiatry. And then at the other end, when they are person's ready for discharge, there may also be poor communication. So I've seen that. I've had patients hospitalized in the last decade who I never knew they were hospitalized till I saw them later at a follow-up appointment. There was no call when they were admitted. There was no contact when they were discharged. I don't know how they think they could be doing a decent job with that. I mean, maybe part of it is I grew up in an older era, a maybe more paternalized era, and largely in the US through the movement of ACT UP and the HIV care movement and people taking more active direction in their medical care. Maybe the good part is that doctors respect or treat the patient's knowledge of what they've been treated with and for and what their conditions are better. But I think we're doing a great disservice in general at a system level because of what a disconnect there tends to be between inpatient psychiatry and outpatient. And I think to some degree that's there in all of medicine. So I'm not sure if that's what so the other thing is, even though even at many of the top-notch hospitals, it's hard to be hospitalized psychiatrically in the US these days. You really have to be saying you're about to kill yourself, or you're want to kill somebody else, or you are so delusional that you are, and impairing your own life has to be there. I mean, you can be delusional, saying all sorts of things and believing weird thoughts, and unless you're threatening others, you're not likely to wind up in the hospital. But even in the hospital, where people are supposedly getting more intensive care, many of the patients I've talked to have described, seeing a doctor only 5 or 10 minutes a day, and often in a training hospital, it's the medical student or the resident rather than an attending. There may be groups, there may be other occupational therapy, or their professionals helping them or teaching tools or doing something else, but most clinical settings are not jam-packed full with treatment options throughout the day. That's so. James Alexander says a few weeks ago, the New York Times, and it's a New York Times Sunday magazine, published an article on post-SSRI sexual dysfunction featuring the research of Dr. Irwin Goldstein, a UCSD urology professor. The article describes his imaging study of internal penile tissue in former SSRI users, finding that the internal penile tissue was black, indicating excess collagen. This is pervasive scarring, which was contribute powerfully, had the same and looked similar to other physiologic cases of erectile dysfunction. So something's jumping way around. So I'm seeing sexual side effects. So what do you think about the issue that SSRIs can scar internal tissue and organs by stimulating free radical production? I mean, to me, it sounds theoretically possible. I have treated hundreds of individuals. Again, usually with SSRIs, I've wound up on lower doses. And I've not had a single person who had sexual side effects that persisted after they stopped treatment. So in my experience, this is rare. The problem is the people who have that or think they have that are going to be upset justifiably. And when you specialize in saying, I'm treating people with post-SSRI sexual side effects, that's all you're going to be seeing. So one question is this a common or pervasive problem? And I'd say absolutely does not seem to be. The other thing that I thought was quite inappropriate in this article on the New York Times, and I did not read it really closely, but I skimmed it, is they didn't emphasize that with depression itself, sexual side effects or sexual impairment is extremely common. At least 2/3 of individuals have decreased libido or other sexual side effects from depression. And every study that I'm aware of with SSRIs, it's just comparing depression to depression alleviated with SSRIs, indicates lower sexual side effects. So the other thing is, at least what I could pick up from the studies, it's not clear how many of these individuals with supposedly SSRI-induced sexual permanent dysfunction had other risk factors besides their SSRI use. I mean, how many of them fit into some of these other categories where they're already high risk? So thanks, Max, for the ketosis and mental health link. So Jay Skatehills is sharing his glucose and ketone experience. Jack X8RX64 is In the Huberman podcast, you mentioned that some of your ADHD patients showed up in the wrong door. Is there any other everyday situation that could suggest someone has ADHD? So the anecdote is that for 2+ decades, I had a home office. There was a completely separate unit at the bottom of the driveway. The door was not parallel to the street, so you couldn't see it readily. It was perpendicular to the street, so you had to go to the driveway, take a left. So it wasn't intuitively obvious, but I gave the exact same instructions to every patient before I saw them, saying, there's a house at 45, there's a office is a separate entrance at 45A at the end of the driveway. And in several hundred or a few hundred patients, when I took the data, the only people who ever went up to the house address were people with ADHD. It didn't mean that everyone with ADHD went to that address. Everyone who was showing up just for depression or anxiety or panic came to the right address. And to me, it represented one of the challenges with ADHD is given a sequential list of data points or information, that people with ADHD are more likely to get off track, not hear all of it, not be able to replicate it in sequence. So I'd say, other situations, everyday situations, just showing, if your friend consistently shows up late for lunch dates or Zoom meetings or text group chats or whatever. So chronic tardiness, there certainly can be other reasons. What else are common? And I'd say, a whole host of ADHD behaviors winds up impacting and affecting social behavior. So James Alexander is jumping back to fish oil's potential for treating ADHD and depression. Your body doesn't make omega-3 fatty acids by itself. Pretty much every doctor also says you can't just convert EPA into DHA and vice versa. If it can, what would be the benefit of taking both instead of just one or the other? If they were fully, an example might be in thyroid hormone. Thyroid hormone T3 and T4 do interconvert. There are enzymes to convert one to the other. But there are clearly some individuals who benefit from primarily just taking a T4 supplement and some who primarily benefit from a combination. So even if EPA and DHA could convert back and forth, if the body preferred or desired a particular balance or ratio, that may be a different ratio than the interconversion would naturally come to. So I don't know if that. So Dennis asks, are there any strategies to get the brain into an alpha state to facilitate learning? And he heard that listening to Baroque classical music can have that effect. I'm sure the neurofeedback, part of neurofeedback is training people to be in a certain brain state. So I don't know specifically what are instructions or advice or recommendations to facilitate alpha state, but I would be extremely surprised if there isn't a whole wealth of people commenting on that and suggesting that in videos online. But I don't know specifically. James Alexander asks, have any of my patients described having permanent side effects from an antidepressant, like SSRIs, that lasted after ceasing treatment? So I treated someone who had extreme gastrointestinal issues after Paxil, which, in addition to being a good SSRI, also has anticholinergic, procholinergic, other neurotransmitter side effects, and is more prone than any of the others to have gastrointestinal effects. So I had someone who was treated and actually had rectal prolapse, so part of their colon was sticking out of their body from the digestive problems associated. So that was a semi-permanent side effect. They I was able to treat them with a different SSRI where they had no gastrointestinal side effects. And over the next several years, there was some reduction in that prolapse. That's rather dramatic. I'm trying to think of other permanent side effects from an SSRI or other. Yeah, I'm not thinking of any. I mean, there are slight associations between certain antidepressants. So there are some higher rates of cancer, and it's not that it increases your overall risk dramatically, but given that developing any one specific type of cancer is a pretty rare phenomena, there have been some associations. I've had at least one patient who attributed a cancer diagnosis to their antidepressant regimen. I mean, this person also led a life of high stress, depression, dysphoria, anxiety, so which themselves can be probably associated with higher rates of certain physical illnesses. So Max asks, since we have limited psychiatrists available, shouldn't we prioritize patients who have clear conditions that impact their lives negatively and pass on patients who have milder periodic struggles? I mean, one is that sort of dichotomizes people into chronic versus periodic. So, I mean, one is if you just look at the depression, I mean, the best predictor for developing a chronic mental health condition is having a periodic condition prior to that. So one is, I'd say one angle is I am surprised. I mean, I've worked with Medicaid and Medicare patients who include people who are on permanent disability. So I was surprised, even among the ADHD field, how often many fellow psychiatrist practices seem to be more the worried well than people more significantly impaired. But I'd say even the people we label as the worried well are in intense distress and maybe having loss of functioning, loss of enjoyment, loss of problems. So I guess the other factor is how do you, I mean, tell a practitioner that they can only work with a certain class of patients or not? Yeah, there's interesting discussions embedded in there, but I'm not fully tapping into that right now. So if you want to revisit that, we can. James Alexander asks many doctors, and I'm happy to keep answering James Alexander's questions. They're usually thought-provoking and good, but I also want to welcome anyone else who might be out there being more reticent to ask questions. James Alexander, many doctors quoted in the popular press, including both clinicians and researchers, exhibit strong skepticism and even contempt for fish oil, claiming that consuming actual fish provides a real benefit. I think some of it's chopped off for fishy. Yeah, so I do believe in general, sort of the Michael Pollan locavore, that eating locally, eating natural things, avoiding high processed things are usually good. One of the problems is I mean, the Pacific Ocean in general is somewhat less polluted in fishing waters than the Atlantic is, mostly given how long Europeans and Americans have thrown junk into the Atlantic. But even in Pacific populations, there's heavy metals like mercury, cadmium, lead. There are organic compounds, like some plastic-based, some non-plastic based, that tend to accumulate in food chains, and many of the fish we eat, like tuna and swordfish that we prize, are at the top of the food chains and particularly concentrate toxins. With fish oil, most of the manufacturers are using a distillation process, so they are, at least for the heavy metals, you're getting less of a toxic dose there. Whether it's as effective for some of the organophosphates and other organic compounds, um, most of those aren't tested as extensively. So, I mean, is it possible that we are missing some of the value or some of the other subtle, although we focus on EPA and DHA and ALA, alpha linoleic acid, there are other omega-3 fatty acids probably found in tiny amounts, or other phospholipid components, or other certainly ingredients in fish that maybe we are missing something. But I'd say probably avoiding the toxins here is more important than getting everything that the fish has to offer. Jack X8 asks, how can I create new synapses in my brain? I'd say anytime you're learning or doing something new, and again, learning doesn't just mean book learning, it can be learning new habits, learning new things with your body, you are forming new synapses. And just more any habit you develop, good or bad. So I would say just developing new synapses isn't necessarily in itself a good thing unless there's strengthening pathways or connections that are beneficial to you. James Alexander asks, for the patients who've stuck with Strattera despite the side effects, what sexual side effects, if any, have they mentioned, and what side effects have continued past the first month or two on their final working dose? So I'd say right now, I think I have fewer than 2 people on Strattera. So I've never been a big fan of it. I've never had large numbers of people coming to me on it. I've almost never started. Well, I tried and saw how few people stuck with it and how many side effects they had. So I cannot recall a single person with sexual side effects from Strattera. Again, my sample size is small. So, and again, unlike Cymbalta, where I felt fairly comfortable predicting side effects in the time course, with Strattera, I've had people who have nausea that persisted. I've had people who felt sedated. I have people who felt over revved up. I've had people who flipped back and forth between those states. It seemed less predictable. So the finisher asks about familiarity with autism and ADHD and PTSD. What medications are helpful with the co-occurring diagnoses? The concern is that, so again, with autism, there's not a lot of extensive evidence that any of our medications so far fundamentally address the core symptoms of autism. So in the US, risperidol and Abilify are approved for treating irritability within autism, but not autism itself. The FDA just is in the process of approving a form of folate for symptoms of autism and cerebral folate deficiency. What's been studied extensively is that stimulants which work for ADHD symptoms do work for ADHD symptoms in the setting of autism. With ADHD and PTSD, one of the concerns is that for many people with PTSD, sympathetic overarousal is a potential problem, and some of them can get worse PTSD symptoms with the stimulants, but not always. So I'd say for something that may be beneficial for all three, I would think guanfacine should be in the mix of things to be considered. I'd say Buspar would be. If I would say I'd be more interested in Abilify than Risperidol in terms of, I think, more potentially helping with dopamine regulation and these symptoms. The finisher also comments there does seem to be greater recognition in adult women having a combined autism ADHD spectrum. I'd say overall, we are still, awareness of ADHD in women has been lacking, but many people have been working hard on growing awareness, so there is much less of a disparity than there used to be. Given that there does seem to be, whether it's for biological or sociological reasons, more representation of inattentive ADHD symptoms in women, that may make it easier to see or recognize or co-occur with autism spectrum symptoms. So James Alexander is following up on the conversion between EPA and DHA. I just don't know how extensively, or I don't know what enzymes might be involved or what steps would be. Yeah, I can't comment intelligently, so I'll just stop commenting on that one. So Max asks, have you had patients come to you with studies to back up their request for specific treatment? Would you consider that appropriate patient etiquette? Should there be a patient etiquette at all? Yeah, I appreciate it. Or, I mean, to me, it's a sign that someone's interested and committed to their own welfare, if they're bringing in or citing specific studies. I'd say more often I hear people citing studies secondhand that they read about in the popular press, which is still fine and good. To my mind, it's perfectly adequate and appropriate. I know that there are some doctors who get defensive and feel that anyone bringing up, particularly from the internet, where there's lots of inaccurate information as well as accurate information, many doctors still treat it as a threat to their authority or competence. But for me, it's just information to engage. I mean, if I have patients who, particularly during COVID, and this is stepping outside of psychiatry, but I have training in biology and general medicine as well. So when patients would cite inaccurate information about vaccines or what's been shown about ivermectin and COVID, to me, it was appropriate to challenge or redirect or show them that there is evidence that refutes what they are saying. So to me, the treatment is a discussion, and my job is to bring my expertise in their condition, my expertise in their treatments for the condition, my knowledge about medications, and what I've perceived or think I've perceived or seen about them as an individual, and to combine that. And their job is to bring in what they know about themselves and whatever else knowledge they have. And it could also be anecdotal information. My friend responded to this, or my mother took this. So, I mean, patient etiquette, I think etiquette might be frowned on as frumpy or rigid rules, but I think the basic foundation of etiquette is respect for other people. That, I think, should be there in most communications. So I think, yes, there should be some etiquette, but I'll stop there. James Alexander brings up, in Flowers for Algernon, the mentally disabled main character undergoes a surgery that boosts his intelligence to a normal level and drastically improves his life, but falls into despair later in the story when the surgery's effects start to fade away and he begins to return to his original state of mental impairment. Have any of your patients on stimulants mentioned feeling a similar sort of sadness or any other kind of mental distress when their medications wear off towards the end of the day and their executive functioning declines to its original impaired level? Yes, I've seen that. I've also seen it occur, particularly in the last 5 years now, 4 years, where we've had shortages of stimulants, which historically were not ever a problem. I mean, before that, people with ADHD had a greater likelihood of forgetting to pick up their medication. And then the longer they've forgotten, the less good shape they are in to remember to get to the pharmacy to refill it. Some of that I have a video on the honeymoon effects of stimulants. So many people, maybe even half of people, have a much more dramatic positive effect of stimulants in the first week or two of use than they ever can recapture. And whether that's a physiologic tolerance developing or whether it's more a psychological effect, that getting back to the euphoria from Dennis of having something that can help you with your executive functions is so overwhelming positive that you overlook what it's still not helping with. So thanks for bringing in flowers for Algernon. I hadn't sort of made that connection, and I think in another way, flowers for Algernon is also a metaphor for life itself, that yes, some of us drop dead abruptly or get cancer at 30, but part of aging is seeing a deterioration of some of our functionings and things we couldn't do when we were 20. So thanks, Max, for providing the stimulants and honeymoon period. So I didn't announce at the beginning, I should have, and maybe I should have, that there are at least 2 weeks in December when I will not be available on Tuesday. So we will just not have a Q&A that week. So I will be here next week, which I think is the 2nd, but it will be the 9th or 10th. And then at the end of the month, there'll be a week I miss again. Yeah, so James Alexander, thanks for asking me to repeat if I wasn't clarified or didn't get into it specifically enough. So my simple answer would be, no, I have not seen any particular advantage of Strattera, Qelbree, or Cymbalta compared to compared to adequate stimulant coverage during the daytime in terms of providing more effectiveness in terms of drop off at the end of the day or more stability. So part of what that highlights is, I think, some of what people are picking up on, jumping back to the sort of the honeymoon and the drop off and the diminution. I think what they are observing more is a decrement in help when a stimulant is wearing off. So someone's appreciating any benefit that it may continue to do less, where there is less drop-off dramatic effect with any of those non-stimulants. But I don't think that really means they are providing more substantial 24/7 coverage, or that when someone wakes up in the morning, they are ready to go and still don't have a slow start to the day. So I think, again, these claims of 24-hour coverage are that people aren't noticing as dramatic a drop off at the end of the day. That would be my observation. And I could be wrong. And again, some of this is open to empirical questioning, which I don't think has been done. So Max says there's something that he vehemently disagrees with me on, and that is sometimes I pronounce marked as marked. And we have a marked disagreement about how it's supposed to be pronounced. And I learned the fancy word. We are in a discussion about orthoepy. Orthoepy is a fancy word for how words should be properly pronounced. I think the only area where I am a stickler is when people throw in consonants, or when I say realtor, when they're sticking in extra consonants or library, omitting consonants, vowels, syllables that are there. But I'd say outside of that, words are all made up creations anyway. And again, not that nothing is wrong, but I think there, I'll stop there. James Alexander, I mentioned the titration philosophy of if a drug is not working, even though you've exhausted it in the therapeutic range, and unless it's producing side effects, ignore the supposed effective ranges and go higher. If you're not getting any benefits and any side effects, keep going up till you see something good or something bad, because unless you're seeing something bad, it's premature to give up on the medication. So specifically, do I follow that with guanfacine and I go up to as high as 7 milligrams a day? Or do I have them stop short of this if they aren't experiencing benefits at, for example, 4 milligrams, even if they aren't experiencing negative side effects? Yeah, I probably will not be laughing. It just not my bandwidth there, but I should smile more. So with guanfacine, I think partly because it works so slowly, I do have lots of patients who get impatient with it, or so I've tried a handful of people above 4. So the other thing to back up is my experience with it is that I've seldom seen anyone who got substantial benefits above 4 who wasn't experiencing at least something at 4. And I'd say there's so this might seem to conflict with what I've said before, and I'll try to think of. So I don't know of anyone I've pushed duloxetine all the way up to 120 who wasn't showing at least some benefit at 60 milligrams. So are there some people who might show no benefit at 60 and are finally showing benefit at 90 or 120? There might, but I think most people are likely to be showing some benefit. So again, more often we're seeing a little or a tiny bit of benefit at these lower or therapeutic doses, enough to warrant pushing higher, and it's not a complete absolute lack of benefit. So there. So that looks like it's solved for today. I don't know what the problems are starting out. I don't know how disorienting it is to view me on the laptop while you're seeing the ceiling, but I hope it worked. And I will be back next week, but not in 2 weeks. Stay healthy, stay happy. It is a crazy world out there. So if you perceive it as such, that's a sign of good mental health.